Hi everyone, thanks again for joining today. We're just finalizing some technical checks. If you don't mind, Dr. Humphrey, I see you online now. Would you mind just checking put your video on for a second and your audio as well? Okay, thanks. Would you mind putting your screen down a bit more closer to your face? Is it a bit, yes, and a bit close, yes, that's perfect. Would you mind speaking a bit?
Thank you. That's
Thank you.
perfect.
Thank you, sir. Yeah.
Okay.
Good morning, all. Welcome to the WHO Africa Media Briefing. My name is Dr. Mary Steven. First, some housekeeping. You can listen to this media briefing either in English or French. Please go to the globe icon at the bottom right-hand corner of your screen and choose your most preferred language. And today, joining us from Brazzaville, Congo, is Dr. Lindiwe Makubalo. She is the Assistant Regional Director, WHO Regional Office for Africa. I will now hand over to Dr. Makubalo to introduce our panelists. Good morning and welcome, Dr. Makubalo.
Good morning, good afternoon, and welcome to all the journalists joining us today for this press conference. Today, we are launching the recently concluded report on universal health coverage progress in the African region. We will report on progress made in the African countries to enhance access to essential health services. This progress shows that healthy life expectancy in the region increased nearly 10 years between the year 2000 and 2019. We will also discuss the latest trends in the COVID-19 pandemic, the efforts to curb the Marburg outbreak in Ghana, as well as the ongoing monkeypox outbreak. For this discussion, I'm very pleased to be joined by Professor Mohamed Ali Pate, who is Julio Frank Professor of the Practice of Public Health Leadership, Harvard Chan School of Public Health. Welcome, Professor. I'm also glad to have in this conversation Mr. Moses Kitele, the Director of Planning, Ministry of Health, Botswana. A very warm welcome to you both. Now, the latest WHO assessment shows that healthy life expectancy in the region rose by almost 10 years to stand at 56 years in 2019, compared with 46 years in the year 2000. No other region of the world recorded a similar increase over the same period, where global health life expectancy increased by only 5 years. This achievement by African countries has been made possible due to a combination of factors, including better essential health services, health service coverage, which improved from 24% in 2000 to 46% in 2019. Other factors include improvements in reproductive, maternal, newborn, and child health. Additionally, the rapid scale-up of health services to tackle infectious diseases such as HIV and TB, as well as malaria, over the past 15 years has been a strong catalyst for improved health life expectancy. While these achievements indicate a significant improvement, we have to admit that life expectancy in the African region is still below the global average of 64 years. Unless countries strengthen and make greater investments in development of health systems, as well as implementing effective catch-up plans, these life expectancy gains could easily be lost. Our analysis shows that African countries experience greater disruptions to essential health services due to COVID-19 compared to other regions in the world. Ongoing analysis of the impact of COVID-19 since 2019 suggests that that it may affect healthy life expectancy estimates. As governments work to restore affected health services, it is crucial not only to aim to re-establish health systems to pre-pandemic levels, rather it is important that significant improvements are made and they are needed to ensure quality, equitable and accessible services for all. A major step towards ensuring equitable access to quality and affordable health services is for countries to bolster public health financing. Worryingly, most African governments fund less than 50% of their budgets. Only 7 countries in the region fund more than half of their national health expenditure. As a result, millions of African households suffer catastrophic health expenditure as they have to pay for their health bills out of pocket. Over the past 20 years, out-of-pocket expenditure has increased in about 15 countries. As WHO, we urge countries to accelerate measures to cushion families from impoverishing health expenditure, improve access to essential health services, including services for non-communicable diseases, which are a growing threat in the region. Additionally, systems for early detection of health threats and other weaknesses in the health system should be improved. Now, turning to COVID-19, over the past week, the continent recorded its first ever decline in cases after a 6-week plateau. The decline is principally due to a drop in cases in Northern Africa. Cases fell across the continent by 44% to 27,000 in the past week compared to the week before. Meanwhile, deaths decreased by 7.4%. Overall, deaths and hospitalizations have remained low across the continent. While cases are currently low and the risk of hospitalization and deaths equally low, the Omicron variant remains highly transmissible and the pandemic is far from over. Aside from COVID-19, we are also supporting countries to improve readiness and response to monkeypox. Together with partner organizations, we are training laboratory personnel, providing supplies to bolster disease protection. In addition, we are collaborating with countries to step up surveillance for monkeypox infection. Over the past 21 days, the Democratic Republic of the Congo, Liberia, and Ghana reported new cases of monkeypox. A total of 352 confirmed cases have been reported in 10 African countries so far. Cases have, however, declined over the past 2 weeks. We are also working closely with the health authorities in Ghana to curb the Marburg outbreak. Across the country, surveillance has been enhanced in all the districts and active search for cases is ongoing in health facilities. To date, 3 confirmed cases, all from the same family, have been confirmed. No new case has, however, been reported in the last 2 weeks. With this, thank you once again for joining us, and we look forward to the discussion and hand over to our moderator for the next speaker. Thank you.
Thank you very much, Dr. Lindiwe, for that elaborate update on the health emergency situation on the continent. And now turning to you, Dr. Ali, Professor Mohammed Ali Pate. Please share with us your perspectives on the future of health and economic resilience in Africa, and also highlight the progress in universal health coverage and your collaboration with the Harvard University. Welcome, Professor Pate, and over to you.
Thank you very much for inviting me to join you in this event. As we have just heard from Dr. Makubalo, COVID-19 pandemic has unleashed significant health disruptions. It has also exerted social and economic costs with losses of many lives and livelihoods. While the African continent may appear to have been relatively spared the brunt of the direct primary health impact from confirmed COVID-19 cases, the lack of adequate testing in many countries still suggests that the pandemic has afflicted the continent much more than what the reported cases may indicate. The report being launched today on the state of health in the continent shares some very good news, including the increase in life expectancy, and that prior to COVID-19 pandemic, access to healthcare has been improving on the African continent over the last 2 decades, even though this was largely for infectious diseases and for maternal, newborn, and child health services, with the access to non-communicable disease care lagging much further behind. The quality of healthcare on the continent has not improved as much, and most people in Africa don't have access to surgical care when they need it. Importantly, as Dr. Makubalo mentioned, we have not yet made much progress on the important goal of financial protection, with millions, with actually thousands, hundreds of thousands, if not millions, being pushed to poverty due to catastrophic health expenditures. Many health systems remain fragile and poorly financed on the continent. And the secondary crisis as a result of the disruptions that was mentioned because of the COVID pandemic has been significant and is likely to reverberate over the years to come. Part of the issue is that African countries have come to rely to a large extent on externally funded vertical programs with less domestic financing for health outside their wage bills. But we have also seen how complementary investments by some national governments and also in terms of their national public health institutions, as well as the emergence of regional institutions, signify the very important role of national and African Union leadership on the continent. Despite the gains that we have seen, health systems are still constrained in the front lines without adequate workforce. Resolving this situation requires rethinking and reimagining a different future for health and economic resiliency in Africa. It also requires difficult conversations on the continent. That is why, in collaboration with the Lancet, we started a commission on the future of health and economic resiliency in Africa called FIRA, which I serve as co-chair based at Harvard Chan School, along with Minister Awa Kolsek from Senegal, and in collaboration with WHO Africa Region, the Africa Center for Disease Control, and United Nations Economic Commission for Africa, as well as other key stakeholders on the continent. The Commission is a multidisciplinary, multi-stakeholder platform comprising African experts and practitioners in public health, health systems, economics, financing, nutrition, climate, with youth representation and also the private sector. It represents an intentionally diverse group with a global African perspective, not an Africa in isolation. We see an urgency to decolonize the public health practice, to reshape African health systems towards autonomy and self-reliance, and to develop strategies and equal partnerships with other parts of the world accordingly. We see the need for reimagining health systems with increased tax-based domestic financing, expanding quality workforce, strengthening public health functions, accelerating digitization in health, with properly regulated and optimized healthcare markets, locally producing our medical commodities and vaccines to improve the health of populations and make the health sector a key driver of economic growth. We see a need for refocusing on producing health, prevention, and well-being in an integrated manner with the consideration of changes in burden of disease on the continent and other determinants such as education, hygiene, nutrition, migration, gender, environment, and climate change. All of this, it is with a perspective to restoring intergenerational equity, shifting the balance of powers towards African countries, and involving the next generation of leaders on the continent. World Health Organization, Afro region, is a very important partner in this undertaking, with the participation of the Regional Director, Dr. Moeti, as a co-member of this panel, and with our plans to have a series of policy labs hosted by WHO Afro, focused on revitalizing the primary healthcare approach, improving hospitals and perioperative systems. So we look forward to continuing on this effort in collaboration with you and other key stakeholders on the continent. Thank you very much for the invitation to join you in this briefing. Over to you, moderator.
Thank you very much, Professor Pate. That's good news for Africa, but a lot of work that needs to be done as well. And now turning to you, Mr. Moses Kitele, can you please talk to us about the Botswana experience in progressing with universal health coverage? Mr. Moses? Yes.
Thank you very much, Madam Moderator. The WHO Assistant Regional Director, Dr. Lidwe Makubalo, Professor Muhammad Alipat, members of the press, other members here present, colleagues, ladies and gentlemen, all protocol observed. As the Ministry of Health in Botswana, it is an honor and a great pleasure indeed to be part of this very important engagement on the launch of the report on tracking universal health coverage in the WHO Africa region. The concept of UHC in Botswana is fully embraced, and every effort has been taken ready to align this concept to our development frameworks, the national development frameworks, strategies, and so on. So it is something that is very critical, central to our government indeed. In the national health policy, Botswana has made a vision of an enabling environment in which all people in Botswana have the opportunity to achieve and maintain the highest level of health and well-being. So this is the cornerstone of our development and our response, or maybe our approach to healthcare delivery in the country. We recognize the fact that each country is taking its own unique path towards attaining UHC, but we still have interesting lessons that we can share as a country. As you may be aware, Botswana is a semi-arid, sparsely populated and landlocked country with an average of only 4 persons per square kilometer, and the second highest population in the African region of about 2.5 million people for the whole country. This makes Botswana makes provision of essential health services particularly difficult in the country. In spite of this, though, we have made some good strides in attaining the UHC, particularly with regards to minimizing financial hardships. Generally, the financial cost of using essential health services are particularly hard on households in Africa for many reasons. One, it could be the direct cost of care, the low cost activity, or the lost income or activity during the care seeking, or the opportunity cost associated with seeking healthcare. Thirdly, it could also be the indirect costs, such as transportation that people generally incur while seeking care. Each of these on their own are really enough to put a household into catastrophic health spending, but all three are usually incurring at the same time, and that is quite unfortunate for our people. Botswana has made or managed to keep these three drivers to a minimum to some extent, I would say. An independent external review of our healthcare sector, which was done recently with support from WHO in June, highlighted the fact that the financial risk protection in Botswana is highest in the African region, with less than around 1% of the households facing catastrophic health spending associated with healthcare. As the report WHO is launching today emphasizes, good financial risk protection is not driven by income alone. Some low-income countries also have very good financial risk protection, while some high-income countries do not. So this is something that we may want to reflect on and see what exactly could be some of the causes to this. The kind of policies pursued by the country has a key impact on the financial risk protection achieved. One may ask, what have we done in Botswana to achieve this level of success? First, the need to minimize financial hardship of the population is integral to the government of Botswana. It is the cornerstone. It is where we start. There's a policy that cuts across all sectors, and different government administrators or administrations over time, making it intrinsic to everything the government does for its people. Secondly, we have resisted the temptation to introduce fees during the provision of services. We believe that putting a financial barrier when people need healthcare, in which in many instances is an unplanned need, will dissuade people from utilizing these essential services, or maybe just creating an unnecessary barrier in terms of accessing the services. We maintain that a nominal fee for service is quite important, at least for us as a government, to provide, or maybe to have, open up accessibility to these services. We also, thirdly, we have multiple insurance mechanisms in the country, which we call medical aids. These are targeting different people from different income groups to ensure that they get the care they need from the public and the private sources. Fourthly, the population has high confidence in the public services, minimizing expenditures in the private sector. So that is also what is getting people to come to our facilities. Fifthly, in an effort to reduce indirect expenditures, the health service network has been greatly extended into rural areas with well-equipped health facilities aimed at minimizing cost of seeking care. And the sixth, the government is financing healthcare for services provided in our countries, avoiding catastrophic spending for essential care not available in the country, but needed by the people. So it is important that we take cognizance of this. We do recognize possible challenges, of course, particularly with financing expenditures out of the country, and also the escalation of healthcare costs generally. As part of the new policy direction that we are working on with the WHO experts in the country, we are looking into ways of maintaining the financial risk protection for the population while managing costs. That is very important, that we find a balance so that our healthcare system remains sustainable. We are exploring medical tourism options. That is some of the things that we are looking at. We have a small population, of course, but we do believe that we can attract other countries and people to come and seek medical care in the country in a way that will help us to have some revenue from this. Where we can, we'll localize highly the technical medical care that attracts users from other countries, and also looking for ways that perhaps we can get reimbursements from the private sector, as they would be paying to the government. That is, have some kind of reimbursement mechanisms that will help us to do that. We are also looking at options such as the telemedicine, coming up with surgical camps and others as means to take needed care into more distant regions of the country. Another question could be, what has this cost us? We have been committed to financing health, which is a right to our people. Government has maintained that. The government is the main source of health spending in the country, no doubt, at about 57% of the expenditure. Even the non-governmental expenditure is still dominated by the private insurance, and government does pay towards those. So predominantly, it is government that is paying for most of the funding in the country. The funding levels within reach for our countries, I mean, in the African region, I think these are lessons that we would want to share, and perhaps other countries can also take up those. Lastly, Madam, let me just summarize by saying that overall, we have maintained a very high financial risk protection through this deliberate policy direction that we have consistently and persistently pursued as a country. And we believe that it has really gotten us to where we are. Our current focus is also to make progress with service coverage to ensure our people are having the full complement of universal health coverage. So with all these efforts, we believe that the quality of services that we are providing to our people will certainly improve the quality of life for our people. Thank you very much for according us the opportunity and space to share our experiences. It's a pleasure. Thank you.
Thank you very much, Mr. Moses. That's excellent news from Botswana on financial risk protection. Definitely a lesson worth sharing with the rest of the continent. We look forward to seeing many more countries making universal health coverage their priority, and also providing services for the less vulnerable without financial hardship. Thank you. So now that we have heard from all our panelists, it is your time, the journalists, to ask your questions. To do this, please use the Q&A function on the Zoom platform. Tell us your name, the name of the media organization you represent. And if you like to go live, please alert us on the Q&A or even raise your hands. Joining us again from the regional office are some technical experts that would be there to answer your questions in addition to the panelists. We have Dr. Humphrey Karamagi, who is a senior technical officer. We have Dr. Fiona Atuibe, a vaccine introduction officer. Dr. Ramadan Otim, health emergency officer. And we have Dr. Ofeo, who is the EP lead for the COVID-19 response. So we are going into the questions straight. Denise Roland from Wall Street Journal. Are you ready to ask your question?
Hi, can you hear me?
Yes, please.
Hello, thanks very much for the presentation. My question concerns monkeypox. I wondered, can you describe the epidemiology of monkeypox that's occurring in African countries? Are these being caused by person-to-person transmission, or is it more that there are more frequent animal-to-human transmission events happening? I think I'm right to say that the epidemic in Africa is not concentrated in gay men as it is in the rest of the world. That being the case, how do you think it is being spread? Thank you.
Thank you, Denise. So I turn over to Dr. Ramadan Otim to respond to Denise's question. Dr. Patrick?
Thank you very much, and thanks, Denise, for the question. I agree with you from the last part that the picture that is being seen in other parts of the world in terms of the epidemiology of monkeypox is not necessarily what is being reflected on ground. So for Africa, we have largely two categories of countries. We have the countries that have reported cases before. There are around 6 countries that have been reporting cases of monkeypox before. And then we have the countries that are newly reporting cases. There are around 4 of them. And those ones, most of those cases, investigations are ongoing to try to identify where these cases came from. Because some of them, there are few countries that you would have a history of travel in the person, but the others, the cases do not have clear epi link, and investigations are ongoing in those countries to try to identify them. Now, if you go back to the 6 countries that have been reporting cases before, in those countries, then you have most of the transmission that is happening at the community level are person-to-person transmission in communities. And some of them, of course, because we have yearly epidemics happening in those countries, those ones usually the index cluster would be linked to a zoonotic origin, and thereafter amplified by human-to-human transmission. So what we are doing now, working with countries, especially the ones that have recently reported new cases, is to better characterize the transmission by undertaking detailed epidemiological investigation to understand how these people could have been exposed. And then, of course, the second one is working with those countries that have previously been reporting cases to also try to understand if there are any other changes in the transmission pattern that they have been seeing, apart from what has been there documented previously, which is a transmission at the household level following an initial exposure to a zoonotic origin. Thank you.
Thank you very much, Dr. Otim. Yes, the situation in Africa is different from what we are seeing from other parts of the world. Leon Lidigu from the Daily Nation, are you ready to ask your question live? Leon? Okay. So if you're not ready, I will ask.
Yes, I'm ready. I'm ready, sorry.
Okay.
My name is Leon Lidigu from the Daily Nation. Now, next week, Kenya is going into an election. And I've been speaking to the Ministry of Health. There's been a push and pull between the Ministry of Health and the IEBC, that is Independent Election and Boundaries Commission, that is running the election. There seems to be no plan in place for masks, for sanitizers, for the voters who are going in these polling stations to vote. In fact, one of the officials told me yesterday that it is good the elections will be held outdoor and the people will be spacing out. I don't know, has the WHO actually advised the Kenyan government, or is there some sort of partnership in terms of keeping these people safe by providing masks and sanitary, and I beg your pardon, and sanitizers? And secondly, there's a new study in terms of monkeypox study that that explains that most of the observations made in the UK are due to rectal and people who are gay getting this disease in terms of sexual activities. Have we observed the same in the continent? Thank you.
Okay, thank you, Leon. You have so many questions. So I will let Dr. Lidiwe answer your first question on advising Kenya on preventive measures ahead of the election. Then we will have Patrick Otim to respond to you on the monkeypox question. Dr. Lidiwe, please.
Thank you, and thank you for that question. Just to respond to the first part of the first question, yes, indeed, WHO has continued to advise all countries on the measures that need to be taken. We have constantly said that the COVID pandemic is not over, and so the advice that has been given is, there's a continuation of that advice being given through our WHO representative in country, that the advice to Kenya and other countries who also have representatives, we continue, that advice continues to be emphasized. So yes, the advice is there, it has not changed, and we know that the message has been conveyed and continues to be conveyed to the Kenyan government and all other governments. Thank you.
Thank you very much, Dr. Lidiwe. Dr. Otim, do you want to jump in on the monkeypox piece?
Yes, thank you, and thanks for this question. I think when I answered the first question from the other colleague, I tried to explain this, and let me be clear on this. We have seen the transmission pattern that's happening in Europe and the study that you are referring to, documenting that a majority of the cases that have been seen in UK and some of the European countries have been occurring in the context of men who have sex with men or gay. So that picture, when we come to the situation in Africa, when we're doing the analysis, for instance, currently 60% of the cases that we have, the 352, 60% are men, 40% are women. So it would be then clear from there that it is not the pattern that we are seeing in our region, because our cases are not predominantly men. And when you look at the distribution of these cases, the places, the different parts of the countries where they are occurring, a number of these cases that we are looking at, over 80% of the cases that we have reported are from countries where transmission has been happening before. And the patterns of transmission that we have seen before in these countries is not in the context of people, men who have sex with men, but is in the context of transmission that happen in households where people who are exposed to initial transmission from the wild, from the zoonotic, then pass it person to person. And you will see this significant proportion of women because of the contact. The women take care of the people who are sick in the houses. So you see that also the women constitute a significant proportion of the cases that we have on the African continent. So for now, that picture is not what we are seeing in Africa. And we then continue to work within the understanding of the transmission dynamics that we have to reduce transmission in the household by focusing on reducing contacts with those people that have that are active cases where the risk of transmission would be high, and then trying to educate the population to minimize the risk with the primary source of the infection in areas where this has been documented in the wildlife. Thank you.
Thank you, Dr. Otim. The next question is coming from Esther Nakazi, a freelance reporter from Uganda. I'm going to ask this question to two people, Dr. Karamagi and Professor Pate. Can I please have a brief explanation on the methodology of collecting the data for this report? What is the way forward after this report? Let me start with you, Dr. Karamagi, and then Professor Pate.
Thanks a lot, Mary, and thanks for the question. I think this is an analytical report, so it relies a lot on information that already exists. So we do not go out and look for data. I think you recall in December last year, we launched the Global UHC monitoring report, which again presented quite a lot of data. Some of the data we was not presented, but we've used in this report. We've also been monitoring the COVID-19 situation or impacts on health services. Every quarter we have been producing some summary outputs. And also we've been carrying out our own internal analysis. So basically it's using information that exists and trying to make sense out of that information, not asking for new data from countries. Thank you.
Thank you very much, Dr. Karamagi. Professor Pate, please.
Well, I think I'll respond more from the perspective of the Commission on the Future of Health. So we have several working groups. There's no intent to collect new primary data. We're going to use existing data sources, make analysis, and then make recommendations that are forward-looking for the policymakers at the regional level as well as the country level, so that the future of health on the continent is better than what it had been before the pandemic. Thank you.
Thank you very much, Professor Pate. And then I'll turn to Paul Adepoju first. Are you ready to ask your question live?
Yes, I am ready. Thank you very much. So my question probably goes to Professor Pate or any other person that wants to answer the question, is on their perception regarding the various moves towards achieving health sovereignty in Africa. We've seen a lot of moves in the COVID-19 pandemic with African countries organizing to access testing and other tools, and also similar moves in other areas. So what do you think, as an expert, should be the key priority towards quickly achieving this health sovereignty? And other question I also have regarding the funding, the financing of UHC in Africa. We've seen a lot of various suggestions being put forward, but it still seems as if there is still a great financial risk for investors seeking to invest in healthcare in Africa, and the fact that Africa is not raising enough funds to be able to aggressively improve its primary health sector, which this report also indicates as a means of expanding access to health services to more Africans. In Nigeria, we recently had the Financial Health Insurance Act. There was a lot of noise made around it, but since it was reported, everything has been quiet, which highlight the importance of seeking policies through the end. So what are your perspectives regarding actually raising enough funds so that Africa's UHC goals can be easily achieved and other key elements of its health sector can greatly improve? Thank you very much.
Thank you very much, Paul. Professor Pate, let's start with you. Then Dr. Makubalo and then Mr. Moses could also complement.
Well, thank you. I think this is a very good question. There are two facets to the questions that were asked. First is in terms of the autonomy on the continent. It's not a sprint, it's a marathon. I think as we move forward, not only do we need to invest in research and development on the continent, by countries on the continent, but also to enable the industry to have the capability to manufacture pharmaceuticals, test kits, medical equipment, and that will take time. And corollary to that is the building of regulatory capacity. On the continent, many of our national regulators are at maturity level 1, largely because we're dependent on huge inflow of externally financed goods to our health systems. But building that regulatory capacity will also help our industry to develop. So medical industrialization is a policy direction that we hope African countries will take, and that it's not a sprint, it's a marathon, and that we do it as a way of not only providing the commodities that we need, but also creating jobs. There's a whole value chain in health. Health is not just about the commodities that we use. There's an economic imperative as well, as we see in many other countries. Health is a large component of their economy. And in the continent of Africa, where we have mixed health systems, there is need to harness and unlock the market potential of the private sector in health to manufacture, to produce, and also to deliver services. In terms of capital, I think the more than half of health services are provided through the private sector in many countries. And there are constraints that are not necessarily only limited to health. There may be constraints on the wider economy and the role of the private sector, but there is scope to harness private capital, to invest in laboratories, in hospitals, but with the public mission protected. Every citizen should be guaranteed basic access to quality healthcare. The public health function should be publicly financed, and tax financing is a key part of that. So the private sector has a role to play, but it doesn't absolve our governments from domestically investing, from collecting the taxes that they need to collect, and prioritizing investing in health. And what we have seen with the pandemic is that lack of investing in health threatens economic security, threatens national security. So health sector is not just about public health services, it's also threatening economic security. So finance ministers and economic planning ministers have a vested interest to ensure that public health outbreaks are contained and that the produce, the equipment, the test kits are available and produced locally, so that they also contribute to economic growth. I'll stop here. Over to you, moderator.
Thank you very much, Professor Pate. Mr. Moses, do you want to complement from the Botswana perspective? Then we go to Dr. Makubalo.
Thank you very much, and thanks to Paul for that very important question, which of course is quite challenging, especially to the policymakers at all levels, including the politicians. I think it's really talking to issues of sustainability, because if we are not able to raise these funds, our systems will not be sustainable. So I think what we really need to reflect on is what is the political will that we can get from respective countries. Let us see the expenditure patterns, the socioeconomic expenditure patterns. To what extent is health given a priority? What is it that we are spending our resources on? Is it on health? Is it on education? Or is it in military? So I think the allocation is something that really is very important. And that's why Prof was talking about ministers of health and many others. We also need to see other politicians really making it something important that we need to get our allocation of our resources right, so that we really give health the care and what it deserves as a socio-economic issue. So it's very important that we speak to our politicians for their political will and ownership. And also in terms of the healthcare delivery, the quality of care that we do provide to our service to our people is quite important. It's a key component because we want to see people who want to pay for quality services. So it's important that we deliver quality services. But again, domestic financing is quite important. We only wish that we do not rely so much on external funding, because that certainly is not sustainable. That also cannot give us, in terms of the priorities that we need as respective countries. So we have to make sure that we have innovative ways of creating revenue and funding for healthcare delivery. So like the private sector is quite critical in this instance. How can we, get the private sector to also contribute to the healthcare delivery? Like I said, for the Botswana experience, it's still predominantly government, but that is not the most ideal situation that we want to see. We want to see everyone coming into play. So it's very important that we have all the necessary sectors part of this. Thank you very much.
Thank you very much, Mr. Moses. Dr. Makubalo, do you want to complement from the WHO perspective?
Yes, thank you. Thank you very much. And thank you, Paul, for that important question. And I can only agree with the intervention made by Professor and Mr. Ketele. I really think that domestic investment is very important. And these are investments that recognize the value of health, investing in human capital. We know, we have seen, and it's been shown that if we don't invest in human capital, if we don't invest in our systems, that it becomes extremely difficult for us to make progress. Further, we need to ensure that we are linking the work and the work in the sector with social and economic development. Social and economic development in the country is particularly important, where the health sector, we have an all-of-government approach. The health sector, I think it has been, as it was said, the health sector has to, the all-of-government approach emphasizes the importance of the health sector, but working together with all the other sectors, the other government sectors, and also looking beyond government, looking at the private sector and all the other non-governmental sectors and so on. And so this really speaks to partnerships being very important. would also like to, maybe one of the things that we need from the health side, I think health security is extremely important. So again, ensuring that our health systems and health security are well built, we elaborate the different components of what needs to be done. And I think this is and I think the other two speakers have said that this is really the route to go. And at the end of the day, I think it's the value of understanding the value of health and health security being appreciated in the all of government and all the wider sector approach. I think that is really what is going to be an important way forward for us. Thank you.
Thank you very much, Dr. Makubalo. We have also seen it from the COVID-19 pandemic that health security is part of everything we are doing concerning development in the country. So I go to Dr. Patrick Otim now. This question is from Cooper Invin from Reuters in Accra. Could you detail to the best of your knowledge how the index Marburg case in Ghana first acquired the virus, what region he acquired it in, and how he came to spread it to his family in another region? Dr. Patrick Otim, please.
Thank you very much for this question. So according to the information that we have received from the Ghana Health Services and our colleagues in the Ministry of Health in Ghana who are leading this response and conducting both retrospective and prospective investigation into these Marburg cases. The index case, first of all, he was staying in the Western region. So that's where he's based. That's where his farm is based. And then he travels, the wife is based in the Ashanti region. So he traveled to the Ashanti region. It's not clear whether he traveled when he was already sick or not. When he went to the Ashanti region is where he sought care at the hospital. So when he presented at the hospital, he had symptoms that were suggestive of a viral hemorrhagic fever. He was managed in the facility until, unfortunately, he died. As investigations were still ongoing, because then it was the Ghana has never dealt with a Marburg outbreak before, any of the viral hemorrhagic fevers in the recent past. So it wasn't deemed necessary to do a safe and dignified burial for him. And then the body was handed to the family and it was taken to the Savannah region where he was buried. So we have three regions that are linked to this particular index case: the Western region, the Ashanti region, and then the Savannah region, where investigations are even still ongoing to try to identify. Now, when we talk of his exposure, where the exposure could have happened, we know the incubation period for Marburg is between 2 to 21 days. So a lot of his movements between this period, it's very hard to document it now when he's no longer with us to tell us where he has been within those periods. So he could have been exposed in any of these places, depending on where he was the 21 days prior to the 22nd of June when he started developing symptoms. So what the Ministry of Health is now doing is to put together a team for ecological survey. They want to do a detailed ecological survey and risk analysis in the Ashanti area, in the Western region, to try to identify where the exposure could have occurred. So they will try to identify some of the reservoirs, the fruit-eating bats, which commonly are a source of this kind of transmission. If they can be able to locate and conduct tests, then we can be able to see whether the potential exposure could have been in the Ashanti region or it would have happened in the Western region where he stays. So we are still far from the conclusive statement on where he got exposed. I think it will be some time after all these investigations have been done. The good thing is then currently we don't have any suspected cases that are being investigated. The third case, the wife is in treatment center. She has no symptoms, and we hope then that soon her repeat test will come back and we find whether she's ready to be discharged. Thank you.
Thank you very much, Dr. Otim. So many challenges with infectious diseases. So this question is coming to you, Dr. Fiona, and then Dr. Makubalo, you could also complement. The question is from Nicholas Bayo from Wall Street Journal. People in rich countries are going for fourth, fifth, and more doses of COVID-19 booster, yet millions in Africa are yet to get a single shot. With the current food crisis driving up malnutrition, spiraling inflation, and historic droughts in East Africa, what's the nature of the state of health for the continent's population? So let's start with you, Dr. Fiona, and then Dr. Makubalo.
Thank you very much, Mary, and thanks for that question. So regarding the people in the richer countries going for the extra boosters, I'd like to inform our dear journalists here that we do have more than enough vaccines now available globally on our hands and even on our continent for as many boosters as possible for whoever wants them. The issue we are still having on the African continent is the uptake of these vaccine doses. And we're even seeing more and more expiries now because the uptake is not as high as we expected. But we're putting a lot in place to be able to ensure that we have more and more people vaccinated, but also to ensure that the people in the highest priority groups, the healthcare workers, the elderly, and people with comorbidities, get fully vaccinated with their primary series and also get fully boosted with the first boosters, and those who also qualify for the second boosters can go ahead and get a second booster. We have enough vaccine to cover the whole world right now, including Africa. Over to you, Mary.
Thank you very much, Dr. Fiona. Dr. Makubalo, please.
Thank you again. Thank you for that question. I think to add to what Dr. Fiona has said, we have, in this report, we have shown that we are seeing increase in life expectancy, and with that goes increases in as we, I think, showed and explained a little earlier, that there have been increases in improvements in disease outcomes for infectious diseases and so on. So we definitely see that we are on the right track, and there are improvements. With the increased vaccination coverage for COVID-19, we are really positive that we will not be seeing huge impacts of COVID deaths as we move forward. So really the forecast looking forward is very positive. And what we are doing and emphasizing today in this discussion, the importance of strengthening our health systems, the importance of universal health coverage and primary health care, because as we are able to deliver better health services, quality health services to our populations, we will certainly be seeing improvements. And as Professor Patti has been talked a little bit earlier about, the importance of development, global collaboration and development to boost economies. That is how we see what we see the way forward to being. And this is exactly how we feel that we'll be seeing improvements in populations within the African region. Thank you.
Thank you very much, Dr. Makubado. And this next question is coming to you, Dr. Patrick Otin. The question is from Chinedu Asadu from Associated Press. Is the monkeypox virus currently spreading in Europe and elsewhere genetically identical to that found in other parts of Africa in the past? Or could this be a new clade with different symptoms? And the second part of the question, is there a possibility that new cases recorded these past weeks in Nigeria and other parts of Africa have been seeded from Europe and are not the indigenous forms? Dr. Otin, please.
Thank you, Chinedu, for the question. Just yesterday, we were checking in the global bank of the sequences that have been done. Currently, we have over 800 genome sequences for the monkeypox, and 400 of them are those that were done. Those are historic pre-2022, and 400 are those that have been done recently. Of those, majority of them sequences from Europe. So when you look at those sequences that are there, yes, they are related to clades that have been seen before in Nigeria and DRC in the past. Of course, you would see that there's a very big time difference in between these, so it was not something of recent, and therefore there's gap in the data which could also need to be filled by having more sequences done in Africa. Unfortunately, we have very few of the recent sequences. So the recent transmission that's happening, we have very few sequences that have been done. And we are working with countries to ensure and then that all these new cases that are being detected, that they are quickly tested and sequenced so that we can have a proper understanding of the transmission from the side of the genomic analysis. So that links to the second question. So yes, we have a number of cases reported in the last 2 weeks, but it is too early then to show whether these ones are linked to Europe or whether they are from the transmission that has been happening within Africa. I think within the next 1 week or so, once the sequences of these are done, we can be able to state with authority whether these are linked or not. What we have encouraged the countries to do is to continue to conduct the epidemiological investigation and try to obtain a history of exposure or travel from the cases that have been reported, but that will not be complete until we have the genome sequences done, which can then try to point to us whether they are linked or not. Thank you.
Thank you very much, Dr. Otim. We are now coming to the end of the presser for today. I will turn back to our panelists to give us their final words. I will start with Mr. Moses, then Professor Pate, and finally, Dr. Makubalo. Mr. Moses, please, your final thoughts.
Thank you very much. And let me once more pass the gratitude for according us this opportunity to engage on this very important topic. Indeed, as Africa as a region, we do need ways of attaining the UHC. And we do believe that so long as we can protect our people and create that accessibility platform for them in terms of financial risk, that will get or improve the quality of life in the region and the quality of healthcare in the region. So we are looking forward really to other countries also relaxing and also coming up with very creative and innovative ways of sustaining the healthcare in terms of providing the necessary resources in terms of allocations from ministries of finance and many others. The role of the private sector is quite critical in this instance, and we are grateful that we have or will continue to have such exchanges that will help us really to learn from each other. Thank you once more, and a great day to everyone.
Thank you very much, Mr. Moses, and over to you, Professor Pate.
Thank you. I'll just appreciate you for inviting us to join you in this event. I'll make 3 points. One on vaccines, on COVID vaccines, just the point that was made earlier. The fact that we have a lot of doses in the continent and demand is low at this point. We should not forget that Africa got the vaccines later than many parts of the world. If the vaccines were available earlier, the demand situation may be different. So a key lesson for the rest of the world is to make vaccines for public health crisis available to all parts of the world at the same time, not to leave one part of the world at the tail end when everybody else has had enough supplies. Secondly, infectious disease outbreaks are with us. There will be more to come. This has been the trend over the last 20 years. But they don't become crises just because they've gone to wealthier countries. On a day-to-day, there are many infectious disease outbreaks that happen in lower income countries. So we all have a responsibility to focus on strengthening public health functions, investing in laboratory capacities, human resources, all the good work that has now been started since the Ebola outbreak in West Africa and with the COVID pandemic, and that needs to be sustained. Just because an outbreak or a pandemic has drifted off the media attention, that doesn't mean we flounder back into complacency until the next crisis hits or an infectious disease travels to a wealthier part of the world before it's declared a huge emergency for the world. So we have to be on the watch out for that. And then finally, investing in health is everyone's business. COVID has proven that. It's not just about ministries of health, it's about ministries of economy, it's about the private sector, it's ministers of finance, it's heads of state, it's citizens holding politicians accountable if they don't invest enough in health. I think that's a key part of what we need to do. Solution will not come from outside. African countries have to seize the momentum and actually decide for themselves to invest, to put their priorities where it needs to be for us to have a much better situation with health and economic resiliency in the period ahead, including manufacturing and research and development, building the workforce, and many other elements that have been discussed here. The road to UHC is an important one. And while we've made progress, there is still a lot of work ahead. And the progress that has been made is very fragile. So there's no room for complacency. So thank you very much once again. And I'll hand over to you, Madam Moderator. Thank you.
Thank you very much, Professor Pate. And now to you, Dr. Makubalo.
Thank you. Moderator. I very briefly, I would like to thank very sincerely Mr. Kitale and Professor Pate for joining in this discussion, thanking the journalists. I think we've had a very robust discussion in a very short period of time, and thank you so much for participating. I think that this report is providing us an opportunity to reflect a little bit, reflect on where we are and the progress that's been made. And I think, as said by the two other speakers, what we are seeing is that there have been improvements that really we are all pleased to see, and we would like certainly to thank countries in the African region as WHO for the effort that's been put in to developing systems and the investments that have been made to bring us to where we are. But as it has been said, we cannot be complacent. There's so much that needs to be done, and especially in the post-COVID-19 period, we have realized and learned even as we, very important lessons, and that we do need to continue to sustain investments, to sustain efforts, to continue to build and to continue to work together. Our universal health coverage continues to be really important. It builds upon, we've been talking about, strengthening capacities, whether we're talking about laboratory capacities, human capacities in the hospitals, in facilities, in primary care, that's built upon our UHC systems. And so we would really like to encourage all of us working together to continue to build on these systems, to continue to invest, and certainly working together, particularly as a continent, would like to continue to strengthen our work with partners, but we've learned, and I think Professor Pate has been saying, we need to be looking within the continent and saying, how do we leverage our resources from public sector, from private sector, from all the other sectors? How do we leverage and work together and build together? And on that, I would just like on that note, I would like to say that it seems to us that we are making progress, but we certainly have a lot to do, and we seem to be ready to move together. And so thank you, moderator. We appreciate this time that you've given us to share our reflections. And thanks, Prof. and Mr. Kitale.
Thank you very much, Dr. Makubalo. And now we have come to the end of the press briefing for today. I would like to say a very big thank you to our excellent panelists and journalists, the technical experts, and everyone who made this a success. Thank you. And let's continue to spread the good words out there to the general population. Have a nice day.
Thank you. Bye-bye.